Hello, everyone. My name is Donna Jacobson. I'm the Executive Director of the IAS-USA. I'm really delighted to present this webinar today that is meant to be a discussion of how leadership in infectious diseases and HIV has been coping in the COVID-19 pandemic. So to begin with, I want to introduce Nadine Kaslow from Emory University. Dr. Kaslow will be moderating the session and bringing the discussions around. With us today are the members of the IAS-USA Board of Directors, Connie Benson. Dr. Constance Benson is with the University of California, San Diego. Dr. Trip Gulick is with Weill Cornell Medicine. Dr. Michael Saag is with the University of Alabama at Birmingham. Dr. Judith Currier is from University of California at Los Angeles. Dr. Jeanne Marrazzo is from University of Alabama at Birmingham. Dr. Chip Schooley is with the University of California at San Diego. Dr. Carlos Del Rio is with Emory University. Dr. Doug Richman is with the University of California, San Diego. And Dr. Paul Volberding is with the University of California, San Diego. With that, we have just a few introductory remarks. Here are the learning objectives. You have them on your materials when you signed up for the webinar. Next slide, please. The financial relationships among the participants are listed here. Next slide. We do have CME for this webinar, as well as nursing and pharmacy credits. All that information is on the website and also in the materials you've gotten. And we want to thank the commercial companies that had provided support for our annual HIV overall program. This is one of the activities in that overall program. And today, for those of you who've been on our webinars before, today we have left the chat feature open for you. So you can chat amongst yourselves and between yourselves. If you have questions though, please submit your questions into the Q&A, that button at the bottom, that's Q&A. So with that, I think we are ready to start. Dr. Kaslow.
Well, good evening and welcome everyone. And I'm really quite honored to be here to help facilitate this conversation today. And I anticipate that I'm going to learn a lot as hopefully everyone will. Again, I want to reiterate to people that we welcome chatting. This is an opportunity to share how you're doing, how you're feeling. And so we actually encourage your use of that forum tonight. So how are ID experts coping with this pandemic? Well, I think Jeanne Marrazzo did a really wonderful job capturing some of this in her Marrazzo moment, entitled Coping with Unexpected Emotion, that was published in August of last year. And I went through that little article and I pulled out some emotion words, because after all, that's what psychologists do in part, is we pay attention to people's emotions. And I just want to share some of the emotion words from that article. Mellow, refreshed, swell of speechlessness, sudden onset of tears, sad, anxiety, futility, hopelessness, anger, powerlessness, self-doubt, grief, and despair. And so these are just some of the emotion words that she captured in her article. And I know these speak to many of us and that there are many more words as well. She ended with a comment, and this is a quote: "Facing reality is never easy, but accepting our current situation and sharing how we feel about it is important. We need to know we are not alone, and we need to openly tell our stories, especially what being emotional and making an honest attempt to be well means in this unprecedented time." And so that what I'm really hoping we can do this evening is have a chance to hear from our infectious disease experts a little bit about their stories, what they've been like emotionally, how they're doing, and what they're doing to be as well as is realistically possible during these very challenging times. So in follow-up to Jeanne's article, what I'm going to invite some of you to share is a little bit about what have been your dominant emotions during this time. And just for the audience to know, we welcome your sharing your dominant emotions during this time. And for each of these questions, only some of the panelists will choose to answer. And that'll be up to them. So what have been your main emotions during this time?
I think loneliness, in part, just the fact that we're not seeing the same array of our friends and colleagues as we have in the past. Zoom does not replace that. We've spent a lot of time, most of us, in our homes, which is fine, but for me, it's not being able to see and have the casual conversations that used to mean so much, even though we never really thought about them.
Mm-hmm. Thanks. So feeling isolated, lonely. What else?
I think anger is a big component. Incredibly angry with the way our leadership at many levels dealt with this pandemic, and how really, science was dismissed, was undervalued. And I think that it just felt like you not only were fighting a virus, but you were also fighting misinformation, quite frankly, politicians not doing what needed to be done. And I think that created enormous anger and frustration in our work.
Mm-hmm. Absolutely. Absolutely. Any other? Yeah, go ahead.
Well, I just want to thank you for calling out a few of the emotions that I mentioned in my piece. And I think one that's really important is grief. And it's grief not only for, the now over 500,000 people who've died, who we really just can't keep reducing to numbers. Many of us have known people, colleagues. We've had some real luminaries in the HIV field who've died. And the thought of people dying alone in hospitals without their families or with remote connections to families, that's heartbreaking, but it's also grieving for all the ways that we do love our lives, right? We get together professionally, we get together personally, we survive because of each other. And that's just been, I think no one was prepared for that loss. And then on top of that, you're grieving it. So it just seems like it's the gift that keeps on giving, and it's not a good gift.
Yeah, I would add that just like COVID, it's a disease of extremes. The emotions are extreme, and it's it's really the highs and the lows, and how they just come almost every day, between feeling guilty and anxious to feeling excited about something that's actually working or happening. So it's the real roller coaster, analogy of just feeling like you're on a roller coaster, but you don't have a seatbelt.
Yeah, and I appreciate somebody in the chat box sort of talking about the roller coaster of that, from really sad to really happy and good times, but also that numbness. And sometimes that numbness, goes with just people being so overwhelmed and the burnout. And I think sort of that over emotionality. I mean, last night when I was watching the commemoration of the 500,000 people who had died, there was all this emotion that came forward, and it's almost like it comes in waves, and we don't know when it's going to come.
There's a real sense of, and this came up on the chat so far too, of fatigue. Is that we're giving it our all, but how long can we continue? And people talked about it being a race and then a marathon, and then now where are we at this point? There are glimmers of hope, of course, and we're all excited about the vaccines and the dropping numbers, yet the day-to-day work continues at a very high level. And all of us are in this together, but as others have said, we don't really have the opportunity to share it.
Mm-hmm.
And we thought AIDS was fast when it hit. We the pace of science was astounding at the time, and yet now we're seeing this with all the new technologies, just putting that in a very different dimension. It's exhausting.
Mm-hmm.
And the comment about PTSD in the chat, I think, is real for all of us. I think I'll speak for myself, the feeling of, having worked in HIV and being able to be a part of so many things that were positive, feeling like we have this opportunity to do it again, but then kind of getting banged over the head about what's not working and all the frustrations. It feels like that's PTSD of like, how can this be happening again?
Mm-hmm.
I think
But in
another,
a way, it feels like AIDS 1994, right? When nothing was working, when people were dying. I mean,
Right.
it's the Berlin syndrome.
Yeah.
Mm-hmm. Mm-hmm.
I think another
Michael,
emotion.
were you going to say something?
Michael.
Oh, hi. I think another emotion is fear. Having had the infection early on, it was a scary experience, the fear of the unknown of what the next day was going to be like. And I think for those who had it, they know exactly what I'm talking about. But even for those folks who never suffered through the actual infection, there was always a fear of contagion. And we're going to go in like shock troops or firefighters or whatever it is on the front lines. And it's one thing to deal with the fatigue and the emotion of watching people die alone and trying to be the conduit between the ICU bed and the family. But while this is all going on and wearing PPE, there's that concern for a lot of folks as they're leaving the hospital and walking home. Did I let my guard down? Is there some way that I might have picked this up? And seeing so many people so ill, that lingering fear it creates fatigue and a lot of ways burnout.
Mm-hmm.
If you let your kids interact with you, we have, but there's a little bit of anxiety and that induces some guilt as well. Like, do I have to worry about my kids bringing this to me? They say they're being safe, but the lack of complete knowledge, I think, is a challenge as well.
I think one thing that's different with the AIDS worst days, even though we were seeing people dying at incredible rates, you could interact with them face to face. They could see our faces, we could see their faces because they weren't covered with masks. And you could have an interaction while they were sick and even dying, while the separation is very frustrating. And another thing that I think is very different is during the AIDS epidemic, we had a sense of time. We had weekdays and weekends, things changed. Here, every day is the same. And you're not quite sure whether it's Wednesday or not. And that creates a sense that you're not sure when it's going to end and if you're in a Groundhog Day type of situation.
Mm-hmm. Yeah. I just want to acknowledge some of the comments in the chat box that I think are really important. One is just this tremendous concern and distress about parents and other people that maybe we can't connect with, and how difficult and sad that's been for people, and watching them struggle or losing things. And I really want to acknowledge that. And another thing that as somebody mentioned got talked about last night and now again I see on the chat box is this issue of you all never being off duty, that you're always on duty, and that's really hard.
Yeah, I mean, every day feels like Wednesday or Thursday. It's always the same. And even when a weekend comes, even if we're off, quote unquote, constant texting from friends of friends who say, I have this friend from so-and-so that just encountered the virus, or how long do they quarantine? And the questions are just endless, and there really isn't a day off.
Right.
The tempo of this disease is also incredibly rapid. We had friends who died of HIV, and many of them had time to connect with their families and to connect with each other and got to know their physicians. And with this disease, we wake up some mornings and find out someone who was a friend of ours has just died somewhere halfway around the world. And that's really something that didn't happen with AIDS. You generally knew they were ill and you interacted with them. And we've had a number of colleagues from our international activities who have gotten infected in sub-Saharan Africa and died without us even knowing they were ill. So you have this sense of impending doom every time an email comes in or you wake up in the morning and hear from someone about someone else. And that is something that really takes a toll.
Right.
Yeah, and it's that, I think it's that loss at a distance over time without really the opportunity to process it. I think that's partly, what you're alluding to as well, is that it happens and you hear it, but it's just so, everything just feels so unreal. And I feel like it's storing up there, and that we all need to find ways to let it out, because it really does, it does add up over time.
Right. And I think, that people mentioned grief, and I think sort of what you're talking about is going to lead to there is a lot of unresolved grief, just a lot of unresolved grief. I want to move on a little bit, but I do want to acknowledge the comment that Bobby made, which is just really so important, which is sort of expressing gratitude to all of you for maintaining your compassion and your sensitivity. And I think it is finding a way, and I think for ourselves and for everybody that we work with, to keep our feelings, to hold on to our feelings, to feel our feelings, to be compassionate toward ourselves and others, and yet not get so overwhelmed by them that we can't function. And I think different days of the week, even though I agree they're all sort of the same, but finding that balance for each of us is really important.
I think, Nadine, that what happened to all of us is the early years of HIV, and still now, but especially in the early years, there was an incredible amount of stigma and discrimination. And for our patients, when you had nothing to offer them as far as therapy, you can offer them a hug, you can offer them compassion, you can offer them a lot of things that I think really shaped how all of us as physicians, as clinicians, practice up to this day. And I think that makes a huge difference. We're not afraid of the disease. We're not afraid of the patient, and we know how to communicate it with the patient in a way that doesn't show almost, I would say that anxiety and that fear that we're going to get something from the patient. And I think that makes a big difference when somebody's talking to you with a disease that, it's unknown, like this one.
Right. So you all have sort of addressed this to some extent, but given who each of you are and your role in the, sort of the HIV experience, if you could articulate, if there are sort of more things that any of you would like to share about the similarities and differences with the AIDS epidemic. And again, you've done some of that, but if there are some additional things that you'd like to add.
I think part of the similarities are I think Carlos mentioned it, the fact that in both situations, the epidemics have revealed the fracture lines of our healthcare system worldwide, and the incredible discrimination that we see day after day. I think there are some similarities there. Sorry, Jeanne.
One similarity and one difference. So what both of these pandemics revealed was the vulnerability of people less advantaged, and people of color, people with less access to care. But one, I think, difference with the COVID pandemic is it's going to have the addition of many more negative consequences for a prolonged period of time to those individuals because of the amount of unemployment and a change in societal structures and activities, which are going to leave, and then the food insecurity, the loss of housing, homelessness that's increased. And I think all of those things are going to have a lasting impact with an even greater separation of wealth between those who are privileged and those who aren't, that we're going to have to deal with for a long time, even when everyone's vaccinated.
Yeah.
Another long-term consequence, obviously, is the long COVID, and those individuals who haven't cleared their symptomatology weeks to months after the initial infection. And that's a little bit more like living with HIV in the early days, because we didn't know what was coming next and we really couldn't explain what was going on. But that segues into another common theme between the two, especially in the earlier days of COVID, where treatments weren't known or readily available, yet everybody had a desire. There was a desperation for the patients and the providers to be able to do something. And then that translated into a lot of input of the politics into the science. And that created, compounded the frustration because of promoting certain drugs like hydroxychloroquine or other therapies that it's understandable why people grabbed onto it, like maybe AL-721 from the AIDS days or Suramin or peptide T. But the point is that desperation, that wanting to cling on to something was very common. The difference was that the politics of the AIDS epidemic was more of just ignoring it. And the politics of this was insertion of medical opinion by political leaders, which was quite frustrating and counterproductive.
Mhm.
One of the
Jeanne, did you want to say something about this?
Jeanne, did we cut you off?
It's okay. I think everybody talked about it. It's okay. Thank you.
Okay, go ahead, Trip.
I was going to say one of the heartbreaking differences is having patients die alone with no family members permitted, no partners, no friends. And that happened now and then during AIDS, but a lot of the time during AIDS, people had wonderful partners, friends, families, support systems. And you could actually be a part of that as the physician as well. And I remember rooms full of people all trying to support the person.
Yep.
This is the opposite. It's really heartbreaking to have people die alone and the only contact they have is with people completely decked out with personal protective equipment or trying to talk to their families on iPads and cell phones. It's saying their last words. It's just really heartbreaking.
Right.
I had one more difference to just throw in there that I think has overwhelmed all of us, and it's the rate of new information coming out. I mean, people are talking about, having to be on call 24/7 to answer questions, but I've never seen anything like this before. The rate at which new things come out and the level of, how well vetted they are, but it just feels overwhelming to try to keep up and feel like you know what's going on.
Yeah, we used to talk about published manuscripts, and abstracts were an exciting new thing where you could find out information early. Now we're looking at preprints, press releases, and rumors and postings, and it's incredible.
Yeah.
I mean, a lot of what we're actually learning is coming to us from the press, not from journals, not from our own colleagues, not from scientists. And it's like they have a constant trolling of every preprint platform that exists, and it suddenly gets escalated to the nightly news. And patients call and ask you about that. And we've been working all day. We haven't even seen the news yet. So we have nothing to talk about. I think Judy is right about the rapidity of the information, but it's not just the rapidity, it's the volume and not being able to sort through the wheat from the chaff. Dr. Schooley and several of us are editors or associate editors of major journals. And the volume of just the sheer volume of reviewing the manuscripts just for COVID that have come into every journal, on every sort of infectious disease related journal on the planet has been so overwhelming. There are days when you don't even want to open your eyes.
It's also been science by press release, right? I mean, you had DSMB press release done at the White House, in the remdesivir trial. And then there was, in November, every Monday, we woke up to see the results of a vaccine study on a Monday press release was primarily a release for investors in that company. Before, none of us had seen any data. And, you at least had seen data previously in meetings or some other place. Now it's all by press release. And it's so hard to then be able to actually answer coherently on science when it's all through press release.
Right. No. Absolutely. But despite all that, each of you were leaders in the HIV/AIDS epidemic, and you are now again in the pandemic. And I'm grateful to each of you for stepping forward and doing so. And I'm wondering if you could share a little bit about what's been your greatest privilege during this time. What are you most proud of?
I'm happy to jump in and start. Directing a division of infectious diseases, I could not be more proud of the faculty and fellows and staff in my division who really took up arms to do everything they could to work together, both in terms of clinical care, getting research studies up and running, our laboratory folks saying, what can we do? We want to contribute. Our hospital epidemiology infection control people out there on the front lines helping other people. I couldn't be more proud of what we were able to do. It's remarkable.
I would just echo that and second that everybody, whether it's an infectious disease, pulmonary, emergency medicine, I mean, the way that people stepped up and the way people, worked and, people could have easily walked out of the jobs and say, this is not for me. But I think people really showed a degree of commitment and dedication that I think, it's really has been, wonderful to see and really something that I wish we could, do something to reward everybody's effort, because this is more than just doing your job.
Yeah, and I would add that it's not just, I mean, I completely agree, the response and what you've seen and what we've seen in our colleagues, both inside the hospital and out, but also in the whole HIV community, the willingness to participate in all levels of this response by everybody. It just feels like, I hate to use the trite phrase of all hands on deck, but it just feels like everyone has been willing to, in our community, has been try to figure out what they can do to help. And that really provides a lot of energy and motivation. So.
Yeah, I was going to say it expands. First off, I think most of the ID folks, a lot of the folks who'd worked in HIV, who'd had that experience, it was almost second nature to step into the vortex. But I've been impressed, at least at our place, and I would bet it's happening all over the country, where from the upper levels of the hospital administration and the health system on through, there's been a responsiveness, there's been a respect for the ID community and genuinely seeking opinions on where to go and how to do it. It did add to workload for a lot of us in terms of participating in conference calls, but much better that way than to have decisions made outside of the spectrum of the expertise that's at each institution and using that. But I've been really amazed at the flexibility of the hospital to expand ICU beds when necessary, to change things around, and the ability of the other colleagues at the hospital to step up, like you said, all hands on deck. It's been heartening.
I think the hospitals also recognize the fact that it was really important to have local expertise because they couldn't trust the usual strands of information they're used to responding to. Our hospital administration watched the CDC flounder under the thumb of the White House, and it became clear that they wanted to hear what we thought when there was a discussion about not needing to wear a mask in the hospital and things like that. So I think it's, as Mike said, it's much more clear now to the hospitals that expertise actually matters. And hopefully that will continue after this is over, but sometimes they do forget. But it's the first time in my career, in fact, that I've seen a hospital administrator be glad to see you as an infectious disease member of the infectious disease division.
I always talk about infectious diseases being like glue. We're the glue that holds everything together, but whoever thinks about glue? You just assume it's there and working. You don't really pay any attention to it. You certainly
unless it gets all over your hands, and
or unless you're a woodworker, Trev.
and you don't pay for glue, right?
And don't touch your eyes with super glue. So I was going to just say too that it's been interesting for me living in a community. I know, not all are doing this the same way, but in San Francisco we've had really a pretty remarkable willingness to follow safe behavior guidelines, and people helping each other stay safe because of that. I think that's another way that the healthcare response has been a positive one in this epidemic.
I would say that one thing that people don't necessarily see, but I think the infrastructure that was built through AIDS research, but also through AIDS care, was incredibly important in this pandemic. I mean, we were rapidly able at all our hospitals to turn our PCR machines that were there to do viral load testing and turn them into PCR machines to do COVID testing. And if it hadn't been for that buildup in that infrastructure to do, in which PCR testing for HIV and other diseases became routine standard of care, you would have not had the capacity to do the testing we did, and you would have been back to CDC and the health departments doing the only testing, because hospitals would have not had that capacity. And I think that, again, talks about how many years of research and capacity building really helped in the response to this pandemic.
That expertise extends to other areas, more basic ones, like the rapid development of vaccines from sequence to emergency use authorization in less than a year is really the consequence of 20 years of research, and a lot of it supported for HIV vaccine discovery, which hasn't accomplished anything for HIV, but it really had a major part in development of the COVID vaccines. And another example, I think, is the whole clinical trials expertise and networks and capacity, which was to a large extent developed for HIV and to some extent hepatitis, which was ready to be revised for all this COVID research.
That's right. We've all been watching a lot of Netflix and other things where you get the fast forward button at 3x, 5x. The actual speed of COVID vaccine development and a lot of the scientific things has been at 100x compared to what we learned in HIV, where the syndrome was described in 81, the virus not till 83. The test wasn't even available till 85. And that's 4 years where we had a lot of that done in 4 months. It's pretty impressive.
Yeah, I had a reporter ask me the other day, are you disappointed that we're a year into this and we really don't have effective therapies? And I thought, wow, a year. And then I thought, well, we do have some effective therapies too. We know dexamethasone works, and we know remdesivir has benefits, and the vaccines are remarkable.
The monoclonal antibody development.
Anything else anybody wants to highlight about this? So there's actually a sort of question in the chat box that I want to ask, and then one in the Q&A, and then and one in the chat box is, is there enough mental health support for healthcare staff? I think we all know the answer to that is no. So I guess maybe the way to frame this is, what would you all recommend be done to help shore up the mental health support for frontline workers, to help with burnout, not just frontline workers, but for everybody involved, to help with burnout, to help with the sense of overwhelm?
Yeah, I mean, there are a lot of resources that are available in our hospital, and there's a lot of talk about wellness and things. And one of the reasons that I wanted to participate in this today is I just think people feel like that's for somebody else. It's not for me. And that just share the fact that everyone's really struggling with this, and that this has not been easy for anybody. And so I think that resources that are being made available really need to be utilized. And people need to, take advantage of it. I know our health system has done a great job of really trying to provide things, but I think not having the chance to just talk about what it's like and to share the feelings that we're sharing here today, I think that goes a long way. I know, that to me has been really helpful, is to be able to, for other people to just know not only are we all in this together, but we're all struggling in different ways, and finding ways to deal with it, I think, is something that we should talk about more. So here we are.
One of the things I'm sure we learned with, go ahead, Jeanne.
Yeah, I think the other thing I'd mention too is that we've all had to learn that Zoom is a bit of a pressure cooker in terms of emotions. So, whenever you meet with people and interact with people at work, there's naturally emotions generated, right? There's conflict generated. I mean, even if it's not major, it can be minor. You may not communicate exactly what you wanted to say. There may be things you didn't say. And, you figure it out, right? You see people at conferences, you see people at the water cooler or whatever. And with this new system, you have to like schedule everything in some ways so precisely that you just don't run into people, right? I mean, maybe you can call them up, but the odds, you don't really know what they're doing. You don't know where they are. And so I feel like not only have we lost the camaraderie of seeing people and just being with people, but we've also lost the opportunity to kind of work through just normal human interaction stuff. And so stuff sits with you a lot longer because you just never really, the day doesn't ever really feel ended, at the end of a Zoom day. I don't know if others feel that way.
Definitely. You can get so much done usually pre-COVID by walking around and talking to people.
Absolutely.
Right?
Yeah.
And it's just not an option right now.
Yeah. There's no open door policy for Zoom.
One of the things that I'm sure we all learned with HIV in the early days is the absolute need to have teams, that it's not all about the docs. It's about all the people involved in the care of the patients that are required for our own health as well. And I think that it's been encouraging to see that, I think, continue with the COVID response as well, where we are maybe more than we have in the past appreciating all of the people that are involved in the care of the patients, not just the docs or even just the nurses.
Nadine, I'd actually like to hear from you about your response to that question, because I think from my perspective, there are so many different types of mental health support needs, and it's hard. As Judy said, yes, there are resources being made available by our hospitals and information about how to access them, but no real sense of, even for us, of what is it I really need? Do I just need to talk to somebody? Do I need medication? I mean, I'm sure many of us have had a similar experience. I can see it on the chat room about just the level of stress and anxiety and dealing with uncertainty each day, and what mental health services help that? What is there that actually helps that? And it may be very different for different people, and it puts you in a situation of not even knowing what to ask for or what to suggest or what to recommend.
Yeah, I'll just comment briefly based on my experience doing a lot of this right now. I think that the traditional mental health model is not the best model for this. Go and make an appointment, and sure, everybody's doing it on Zoom right now. But one of the things that we found is that people, like, calling a therapist is like one more thing. Calling a psychiatrist is one more thing. And so we've really found that it's worked best. We're actually going on to the units. As Carlos knows, I've been going to all the COVID ICUs in our system every week since last March, and providing support in ways that I'm sure every book written for a mental health professional says don't do. They tell me, I'm supposed to sit in a room and promise confidentiality and have the door closed, and people are needing to watch whether their patients are crashing. They can't be in a room that way, and it's not safe to be in a room. And so what's it like to do support groups at the nurses station? What's it like to go into the resident rooms and the call rooms and just, or walk around the hospital and provide support that way? And so I think this sort of traditional mental health model is not the right model for this. We're seeing, we have a clinic that's open from 6 a.m. until midnight, where you can just sign up online and get a therapist in our system to talk to you basically. So I think that we just need it to be much more integrated. I also think that So that would be, those are a couple of things. And I guess the other comment that I would make is a lot of the quote wellness offerings I'm all about, but if I hear one more surgeon, anesthesiologist say to me, I can't do yoga at noon, like this is ridiculous. You know, yoga at noon is just like, how am I'm in the middle of surgery. And so I think offering wellness things that actually can be accessed by a reasonable number of people and help people do this. So I had surgery, shoulder surgery in December, and I needed to do my PT every 3 hours. And so I was ending meetings early, 10 minutes early to do my PT. And about 2 weeks into this, you know, my faculty and trainees said to me, could you keep doing PT forever? And clearly what they were saying to me is, can we have 10 minutes off at the end of each meeting? Like that would be more helpful than yoga at noon. And so I think that sort of, you know, building in kind of some of these little wellness things really matters. But I also think, and I've talked to countless house staff and attendings about this, a patient dies, at most you get a moment of silence. If it's a really compassionate unit, you get a moment of silence. And then you go on to the next person. There's almost no time in rounds to talk about it. It's like, and so I think that part of what we're doing, you sort of mentioned, Judy, the grief that just builds up. I think we're contributing to that. And I think we need to do a better job every day of stopping when somebody dies or somebody gets really sick and checking in with how people are doing. I think we need to shift our culture in the systems so that we don't all, somebody mentioned it, get numb because it's too overwhelming and it just becomes one more number. I'm going to move on right now. During this time, what have been some of your biggest challenges professionally? And how have you addressed these? What are you struggling with? Everybody, people love 10 minutes back. All right.
You know, I think one of the biggest challenges, as it was said, professionally is sort of, at least for me, has been navigating this very complicated political arena. And this is simply not just science, and the politics are in the middle of it. And you know, I mean, I can't, you know about it, but you know, the countless hate mails, threats, personal threats that I've received throughout this pandemic. I mean, I can almost tell you, it's you appear in CNN and you say something and you get, you know, 20 emails of people telling you, you know, you're going to die, you will, you know, I will make sure you lose your license, blah, blah, blah. It's difficult. And it really is, it's very, I mean, stressful, scary, and frustrating. And sometimes you feel like, you know, I'm not going to do this anymore. It's too dangerous. It's too frustrating. But you feel that you have to, that somebody has to be out there. So I think the frustration of combating, I mean, I think that the politicizing this pandemic has really been, for me, one of the most frustrating and complicated things to deal with.
I think a common theme for all of us really is that prior to COVID, there was other stuff that we did. And that stuff doesn't just go away because COVID's here. So we're always in this balancing act between doing those things, and all of us are HIV docs. And so staying up with that, which we've been able to do at least clinically, and go to the HIV clinic or attend on the wards. But on top of that are the research projects that we've been involved in, but maybe more importantly are the projects that people who we mentor are involved in, younger faculty, fellows, trying to help them stay focused on the projects that they've committed to do. If they have an R grant or a K award, the time doesn't stop because COVID's here. And then that is, I think Jeanne was saying, the inability to just kind of connect in person. Zoom is okay to a point, but the water cooler conversations, the spontaneous meeting in the hallway, sometimes is where the best advice comes out. And I think that's, for me, that's been the biggest struggle.
Thanks. What about for other people?
I mean, I feel like, you know, I'm just developing a severe case of attention deficit disorder, but like not having more than 10 minutes or 5 minutes or even 1 minute to do things, and then you're pulled in another direction. And it used to just be a little more space in between to have time to think or to finish things, but it's just rushing between one thing and the other and always being behind. You know, it's which of the things is the most late of the things that are late, and who am I going to disappoint today because I didn't do something. So that just constant feeling of I'm not keeping up, and just needing to sort of put that aside and do nothing for a while. We used to get on airplanes and sort of try to do nothing for a while, and I don't have that time anymore.
I think that the biggest challenge for me has been keeping our research unit intact. And while to some extent we've been able to cross-utilize our personnel from our HIV research activities to cover clinical trials for COVID and for vaccine trials, inpatient and outpatient research work, not all of those people had the skills to be able to do that. And I think I'll just give a shout out to Judy. Judy's the head of the AIDS Clinical Trials Group Network, and that network in particular has been really tremendously supportive of the research activities in a way that's given us the financial support to be able to keep people employed. So we've been able to keep our research unit going, even though we weren't doing any research for months at a time, but keeping a job in an institution for people that were deathly afraid of both getting COVID and of losing their job and becoming like the rest of the world, jobless and homeless. We have a lot of younger people in our unit who had kids at home and having to transition to staying at home and taking care of their kids and teaching their kids and not being able to send them to school has also had a big impact. So I think the NIH in particular has been really tremendously good about supporting the NIH related research units in a way that's both allowed them to be used as infrastructure for COVID research, but also allowed us to be able to support the staff that we've had on hand for all of our HIV research and keep them there so that hopefully as we work our way through the pandemic, we can bring people back and bring the research projects back online. So I think that's been a tremendous challenge, but also one of the good things about maybe a silver lining. We were talking last night about, are there silver linings in the pandemic that we can point to? And I think that's been one of them. I was deathly afraid when all of this started, we were going to be laying off all of our research staff. And that has not happened, which is one of the silver linings of some of the work that people have done advocating for our HIV program.
Great, thanks. Other kind of big
I think
challenges.
another silver lining has been just being forced to spend a lot of time with my family, which turns out to be really, really wonderful. And I realize how much time we actually did waste traveling and, this meeting and that meeting and missing out on how things were going and being able to reestablish some of those relationships. It doesn't sound like that's possible for Judy if you're working 99% of the time, but some of us are starting to slow down. And I think it's been actually a very positive thing in a lot of ways.
We'll get to the silver linings for more people in a minute. Any other kind of big, or some additional silver linings, any other big stressors for people?
I think the
Yes.
patients, for many of us, when, our patients living with HIV all of a sudden couldn't come to clinic, and we try to figure out how to get medications to them, how to continue providing care. You couldn't do testing. I think quality of care overall has suffered. And we've seen this in not only in HIV, but in many other diseases. We've seen an increase in mortality from cardiovascular diseases, from strokes, from other diseases as a consequence. So quality of care has dropped for all diseases and is not just COVID. And I think that clearly contributes to the excess mortality that we've seen as a result of this pandemic. Clinic through telehealth at some point in time is just not the same.
Yeah, so that was actually one of the questions, had to do with, does it fall short? Some people not accessing, how do you reach them if they're not? So that's actually one of the questions, if anybody wants to comment on that.
Yeah, I want to thank Jules for that question in the comments and the chat about this issue, about what is happening to people living with HIV, being able to access care and get the services that they need, and being deathly afraid of going outside. And, I think people are starting to measure and study this. And I think that there are some things about remote care that have helped some people, but it's clearly not a full substitute. And, I think we'll utilize some of it in the future to, particularly in a research setting, realizing that people don't actually have to come and see you for every single visit. We can reduce the burden, but there is that need to connect with people. And I think this feeling of being disfranchised, and, we all think that stress contributes to, we all know it contributes to our long-term outcomes. And so I think there's no question that stress is having a negative impact on people living with HIV.
So since y'all wanted to get to the silver linings, and we've heard some from Connie and some from Paul about silver linings, how about if we talk a little bit about other silver linings, and then I want to get to the question that got asked about teams. Well,
I'd comment, going back to Doug's earlier remarks, that the speed of the science has been really so tremendous. And I think this is a great opportunity for the public to appreciate, that we have some amazing tools now. And one would hope that, that the mRNA vaccines won't just be used for COVID, but they're going to be used for other infections as well. So I think looking at the silver lining of the benefit of the investment in basic research is going to be a really important outcome from this pandemic.
I think another silver lining, we've just alluded to a couple of them, but they also have detriments. So telehealth is something we've been talking about for a while, and we were forced to implement it because of the pandemic. And I think there are huge limitations to it, as we talked about, but there's also the benefit. And I think trying to figure out where that can linger or where it can continue on in the right kind of way is going to be the challenge once COVID hopefully is over. The other thing is the value of Zoom. We talked about the better value of being face-to-face, but I think a lot of our travel has been replaced by some Zoom conferences. And when you add up the time to get out, drive an airport, get on a plane, land, go to a hotel, there's a lot of time in there. It is personal time where you can kind of rest, but it's also time. And just having someone give grand rounds from across the country without having them have to fly all the way in, you miss the interaction for sure, but you can get the information. So trying to find a balance of how to use Zoom instead of travel on occasion might be a legacy that turns out to be a silver lining.
Mm-hmm.
For me, a big silver lining, I hope, is going to be that people are finally going to understand the value of public health. I mean, the great majority of Americans had no idea what public health even was or meant. In a survey done not long ago, people thought public health was taking care of the poor. And I think public health will get a boost, and I think public health hopefully will get an investment that it desperately needs. We have had years of disinvestment in public health, and my hope is that people will finally realize that we needed a strong public health, and not having a strong public health was one of the big impediments of a good response to this pandemic.
Another one to add is just the emphasis on doing good clinical research to identify therapies and prevention strategies that actually work. And HIV certainly revolutionized infectious disease in a lot of ways in doing that. And COVID has just supported that too. We really do know how to study things. Even in the middle of a pandemic, we can do excellent, well-powered, well-thought-out, well-designed, well-carried-out studies that lead us to results that really make a difference for people. How important is that?
I see there's, oh, go ahead. Go ahead.
I was just, maybe you were going to just do this, but there's been some really good comments in the chat that I think it might be helpful
Right.
for us to get to. One
Yeah.
of them
Was vaccine hesitancy. I see.
right,
That's one big one.
and the other
Right.
one Dr. Schooley brought up related to many of us, we are all talking about getting on a plane and flying to places, but I'd say the majority of us actually do a lot of international work and working with our colleagues in other places with our HIV research programs. We've seen the impact of maybe 20, 30 years of investment in many of the countries where we work, leading to improvements in their healthcare infrastructure, their healthcare systems, and health professionals' education in those countries. But it's a very tenuous situation right now. And I think many of us are very concerned about what's happening in those areas that we've been working and now can no longer work. And how are we coping with that? So one of the people in the chat room is talking about team members in many of the countries where many of us work, having to take care of prime ministers and having to take care of their own colleagues in the hospital. Dr. Schooley mentioned losing one of our major colleagues in Zimbabwe. We've lost several other physicians who were leaders in their fields in some of these countries to COVID. One of the ways that Dr. Schooley and I have been trying to cope with that, and building on Mike's comments about Zoom, is we've been interacting on a regular basis with our colleagues in international settings on Zoom, and doing kind of what we're all doing today is talking about the experience that we've had treating COVID here and how they can take that experience and translate it to the setting that they're experiencing in their own countries. We've done one seminar on treatment and going through trying to sort through the enormous information from clinical trials of inpatient therapies. We're doing another one on respiratory management and oxygen therapy for countries that don't have ventilators, and how do you manage that? So it's a way for us to still connect with our international colleagues and be able to do it by Zoom, which is, I think it's been a tremendous help to us in being able to continue that communication without being able to get on a plane and fly there and see them and help them deal with a pandemic in their own settings. So I think that's really been a silver lining, but one that is built on a very tenuous base in many of the countries that we all work.
So other comments about the global, oh, sorry, go ahead.
I was going to follow up on the global issue. One of the things we learned with HIV is that our colleagues in international settings know what the right thing to do is. They know which drugs work. They knew D4T wasn't a drug they wanted, and they had a lot of international organizations saying D4T is good enough for you. Tenofovir is too expensive, and we don't need to have that repeated with vaccines for two reasons. One, it's the wrong thing to do, and secondly, it's a great setup for continuing to watch these variants evolve. And we are in this together, and this America First policy has been a disaster across multiple fronts, but it would be particularly disastrous had it continued to be applied to dealing with COVID. We have to deal with this globally, or we will not be able to deal with it locally.
I agree with that, and I think the excellent question about vaccine hesitancy is worth considering. The proportion of people who've expressed hesitancy is really frightening, because there's no way that continuing transmission isn't going to be controlled without saturation of the public. And a special concern is that the hesitancy is increased in the most vulnerable populations, those most at risk, including people of color and people with less access to medical care. And it's going to be a very important issue to figure out good ways to inform and behaviorally modify that hesitancy, or we're going to be in deep trouble. I mean, one thing we do know is that we will never eradicate this virus. Unlike SARS-1, which was eradicatable because it's not as transmissible, those same measures won't work for SARS-2, which is so transmissible. And in addition, there's always additional potential problems like animal reservoirs. The virus has been reintroduced into mink and dogs and cats, and could go into all sorts of other animals as a reservoir that could reemerge, even if we suppressed it significantly. And the other concern that's always possible is the emergence of variants that will create a influenza type situation where we're chasing new variants. And so we really have to figure out ways to get the globe vaccinated as well as possible and overcome the hesitancy.
So I guess I'm wondering, as you think going forward, what are each of your thoughts about how you might best channel your energies, or how other people on the call can channel their energies to be most helpful with some of these vexing challenges?
I'd just like to say one of the aspects that may help overcome hesitancy is people seeing the impact of the vaccine on mortality and hospitalization. There's already some very impressive data out of Israel where they've had a little more saturation. In terms of the impact, it's like almost 99% reduction of mortality, which goes along with the phase 3 studies. And the Brits have now generated some early data. And I think once people see the magnitude of safety and the impact on disease, it may overcome some of the reservations that people had. And some people did have reservations because of the speed of development. And I think time will be one major contributor to hesitancy. It can't overcome disinformation and other universe thinking.
I think it's going to boil down a lot to just flat out communication, but communication has to be a two-way street. We can't just assume that we know why the hesitancy is there. So I think the first thing we're going to need, or continue to need, are the town hall situations where, rather than just starting out addressing all the points and trying to convince people, sit back and listen and hear what they are. I mean, some of it is, as we've already talked about, that the speed created the impression that corners were cut, and the use of the term warp speed, while I understand it, sort of underscored that concept of maybe corners being cut. But for example, in our neck of the woods, the whole mistrust of the healthcare system, the disparities that we talked about, but even going back to the Tuskegee Institute clinical trials that were done in a terrible, unethical way, those echoes still exist. And understanding, listening, and then having peer groups discussing. We're talking about using barbershop approaches where information can be shared, but we got to be creative. We got to be somewhat patient, but above all, understanding that communication's a two-way street.
Yeah, I would just really, sorry, Trip, go ahead.
No,
Go ahead.
Yeah, I would just really amplify what Mike said. There actually are really good data to show that data doesn't convince people. So just telling people this is your risk of this is so much less if you get vaccine. It's a non-starter. You got to really sit down with people and talk to them about what they're thinking and not come in with a preconception that you're going to be able to persuade them. And I know that sounds basic, but we're so used to being able to do that or thinking that we can do it. I think the other thing is, you know, when you think about vaccine hesitancy, a lot of the people we're talking to are people who've never been able to trust their healthcare providers. They've never had a circumstance where they've had access to trusting, confidential, consistent, caring, solid healthcare because of the frayed infrastructure of our healthcare system. And so why all of a sudden should they, you know, listen to somebody like me or Mike or any of us who's telling them from on high that they should get a COVID vaccine? It's just not a reality for them. So the trust is really not there.
I think a variety of approaches are what we need to do, and everything that's been mentioned is important. One thing that's really, I've had my eyes open to is to do it one-on-one with people and to make sure that you have members of communities that you're trying to reach out to be part of the message. We had one of our staff members was absolutely against getting the vaccine, and finally one of my colleagues sat down and chatted with her, and actually after the conversation took her to go get the vaccine. Her major point was she didn't want to get it without having someone close by, and she got it. She came running back and said, "I got it." So one-on-one can really make a huge difference when it comes to vaccination and vaccination hesitancy.
Yeah. Yeah. And I think probably, you know, you're all right that you really need sort of creative approaches, but it cannot just be the science driving this, because those people are already vaccinated. The people where the science is going to speak to them are probably people on this call who, you know, took a picture of getting the vaccine and posted it on Twitter or Facebook. I mean, that we've already heard the messages. And so I think we need different approaches now for sure. One of the questions that got asked had to do with sort of teams, and how do you help support teams during these difficult times? What recommendations do you have to help teams?
Respecting each other. Or I think, you know, the fact that there are still some people in the healthcare system that haven't been prioritized for vaccines, even though they're definitely part of the response. I think there's a lot we should be doing to increase the dialogue that we have with each other. I think it's happening, and in part because of what we experienced with HIV, but I think we could be doing more.
Do you remember that old show, Hill Street Blues? They used to have the meeting of all the cops together, and the sergeant would always end the meeting by saying, "Let's be careful out there, take care of each other." And we've been kind of doing that, just repeating that. Let's be careful out there, let's take care of each other. And I think just doing that on the micro level, having people look out for one another, really goes a long way.
We actually set up an informal buddy system early on here. I don't think you got one, Mike, because we didn't think you needed one. No, I'm just kidding. We all take care of you. But we did, and it's been pretty great. I also, as the division director, have tried really hard to reach out personally to everybody every few weeks or a couple of weeks. I mean, it's hard because I don't want to be intrusive, and I'm not a therapist, so I can't, you know, I don't know if I'm helping, but I think people need to know. Again, it comes back to telling stories and creating space for people to say, actually, you know, it sucks. I had a horrible day and I don't feel good.
Yeah, and I think just as always, acknowledging everyone's contributions and their role. I think people feel like they're on this treadmill and they're running and nothing is happening except they're getting tired. And to stop every once in a while and say, look what you did, look what's been accomplished by this work. I think that's so important for all of us. And you know, I was saying the other week, I would love to just start all Zoom meetings at 15 minutes after the hour rather than on the hour, to just create more space in people's days. And I think that's something I'm going to try to do.
Give it a try. Give it a try.
Yeah. So Judy, that actually gets me to my final question for all of you, but actually for everybody in attendance as well. I want you to each take a minute and pause and think about one thing you heard this evening. One small thing that you can try to do a little bit differently to increase your own wellness or the wellness of your teams. Just one small thing. You can share in the chat box. I want everybody to make a commitment to doing one little thing differently. And if the panelists would be willing to share what they're going to do differently.
Well, I'm going to speak up first because I think your approach, Nadine, was the most popular in the chat box, finishing your Zoom calls 10 minutes early. So somebody has 10 minutes left in the hour to reflect on things before they have to Zoom to the next Zoom call.
Yes, start them 15 minutes late and
start
end them 10 minutes early.
Yeah, I think that was really that really had a connection to me. So that's one thing I'm going to take away.
It looks like reaching out for people that you're responsible for.
Yeah, I think one thing is not to feel, I mean, I'm going to try not to feel guilty for taking time for myself. And I think that, you know, one of the things that saved me during this pandemic is that I started running again, and I live in a really great place for that. And I don't have to drive some days to work, so I have more time, and I really, really value that. And some days I feel like I don't have time, but I'm just going to keep making the time.
I think it's too easy to isolate and to cut people off and to not speak to them. And there's good excuses. We're all busy. We're all concerned. People are living their lives, but we need to re-engage and reach out to people that you haven't spoken to in a while, including the group on this call.
Yep.
Mm-hmm.
And I also suggest we end at 1/4 after.
Oh,
good idea.
Right on the dot.
You're a fast learner that trip. A fast adopter, I should say.
And we're just a moment away from that 1/4 after.
Right. And so I guess I just want to end with a couple of comments. I guess one thing I'm going to do differently based on what I heard last night and again today is be a little bit more mindful when I reach out to my ID colleagues at all hours of the day and night to ask y'all some question. I sort of feeling guilty about doing that and realizing that 10,000 million people are doing the same thing. And so I'm going to try to be more respectful to Carlos and people here, and hopefully by extension to all of you. But I really want to thank all of you for your openness and your honesty and your compassion for each other, and for the patients and for your teams. And I guess end on kind of what Judy said, which is just to make sure you mobilize that compassion toward yourselves. I have a feeling that this group here, both the panel and most of the people on the call, are really good at compassion toward other people. Probably get A++, but I'm not sure you're all getting A's in self-compassion. So I'm hoping you all, and I'm on your team, on that one, I'm on your team, that we all can get a little better at that during this time, or one day we're going to wake up and we're just not going to be able to go anymore. But thank you for all you do and all of your leadership, and for inviting me to share with you tonight.
So Donna,
Nadine, thank you so much for doing. Oh, go ahead.
One comment in the chat was that we mentioned early on Jeannie's article, and I think people are asking if that link can be circulated. So that looks like
it was put in the chat.
Yeah, I put it in there. I put it in there again. Thank you, Connie.
All right, thanks.
And we'll make sure that the on-demand webinar has the link as well. So we are right at the 15 minutes. Nadine, we just can't thank you enough for doing this with us. This
really
has
great.
been really, really terrific. The thing that I missed right now is that we're not going to hear the audience clap and thank all of you for doing this, for being able to step out of your day-to-day role to take the time to do this. I think it was a wonderful idea, and I think we can tell from the comments from people that it's really been useful. And thank you for your honesty and for your bravery on this. Just a couple of notes I think we have for, there is CME offered with this. I think that self-health is probably one of the most important of the CME missions. So those who've attended will get their link to getting the evaluation, and please give us comments. Really appreciate it. By tomorrow at end of day, they'll be processed. There's lots of information on the IAS-USA website. This is just for those of you, quickly, you can get this on the website as well of what's coming up. And then also what's coming up in the courses and some more of the dialogues, which I know I see a lot of familiar faces and names on that. And so thank you to everyone. And thank you to the absolutely amazing IAS-USA staff who work behind the scenes very silently and productively to put on all these different activities while staying safe. So everyone, to our audience, thanks for the great comments. Thank you for participating in the chat and getting getting a lot of these ideas through. So I think that's it. Please, everyone, stay safe, be kind, and be patient.
Thanks, everybody.
Bye-bye.
Thank you.